All right. Good morning, everyone, and welcome to our VCU Cardiology Grand Rounds. My name is Zachary Gertz. I'm one of the interventional cardiologists, and this morning it is my great pleasure to introduce our first speaker, Dr. Vaishnavi Gadella. Vaishnavi is one of our third-year general cardiology fellows. She's born and raised in India, completed her medical school training from Medicity Institute of Medical Sciences. She graduated with honors. She moved to the US as a research trainee at the University of Pennsylvania, where she studied cardiac imaging. She completed her internal medicine residency at the University of Connecticut before coming to VCU for general cardiology fellowship, and now she is our chief fellow for education. She is pursuing a career in interventional cardiology and will be heading to Baylor College of Medicine next year. I just want to say personally, having worked with Vaishnavi for the last few years, she is the best prepared fellow for interventional cardiology that I have ever worked with, which is a testament not just to her skill, which she has, but to her amazing work ethic. And I know I speak for all of us when I say we are very sad that she is leaving us for interventional training. And the only silver lining is I hope everyone she works with thinks that she is just typical for a VCU fellow, and this is how we train everybody. This morning, Vaishnavi is going to teach us about the expanding role of TAVR, and Vaishnavi, take it away.
Awesome. Thank you so much, Dr. Guts, for that introduction. I'm really happy to be here today for Grand Rounds, especially alongside my dear friend, Dr. Prabhu. I'm excited to talk about TAVR, a topic that feels very timely and important. It's a field that's evolved rapidly from a last resort for surgical turndowns to something much beyond that. So let's take a look at where we started and where we might be headed next. So this is a landmark figure from the Braunwald and Ross, published back in 1968, that first outlined the natural history of aortic stenosis. They described a long latent period where obstruction gradually increases and the myocardium compensates. But once symptoms appear, the survival drops sharply. On average, patients had about 1 to 2 years to live, and nearly half of them died within that time if left untreated. Back then, the challenge was timing. Waiting too long meant irreversible myocardial damage, but operating too soon came with a substantial surgical risk and unreliable valve technology. Fast forward to today, the natural history hasn't changed at all. The survival drops off after symptom onset. What has changed is when and how we diagnose these patients. With improved imaging and longer lifespans, we are now seeing symptomatic aortic stenosis more commonly in the seventh and eighth decades of life. In many ways, we've moved from trying to find the least bad time to operate to actively identifying the right time. But even with that understanding, we weren't always able to act on it. In the early 2000s, this is the EuroHeart study that showed that nearly 30% of symptomatic patients over 75 weren't offered valve replacement. At the time, surgery was the only available option, and many patients were deemed too high risk, either due to age, due to frailty, or comorbidities. So, despite knowing the prognosis, many were left untreated. And as we've seen, that often meant facing a 1 to 2 year survival window. So it's on that background that transcatheter therapies and partner trials in particular changed the conversation. The partner 1B trial showed a clear survival benefit with TAVR in inoperable patients. Then the partner 1A proved that it was non-inferior to surgery in high-risk operable patients. This really opened more doors for TAVR and led to FDA approval for symptomatic aortic stenosis in high-risk patients. From there, Partner 2 expanded into intermediate risk with similar outcomes to SAVR. And finally, Partner 3 showed that in low-risk patients over 65, TAVR actually had better outcomes at 1 year. And with all of that impressive data, it's not surprising that the TAVR volume in the US has grown rapidly over the past decade. We've seen over 100,000 TAVR procedures being performed annually in the US. While the SAVR volume has declined slightly, what's important here is that the total number of patients receiving treatment, either TAVR or SAVR for severe aortic stenosis, has essentially doubled, and that to me is a major win. We've also gotten better at doing the procedure. When the TBT registry was first launched in 2012, the in-hospital mortality was over 5.6%, and now it's under 1%. The stroke rates have come down to 1.4, the pacemaker rates are around 7%, and conversion to surgery is just 0.27%. That's actually lower than some of the PCI stats. The length of the stay has also dropped dramatically from over a week in early years to now a median of 1 day, which is pretty less. So the question to ask is, should we TAVR everyone now? The current ACC/AHA guidelines, which were last updated in 2020, they draw a line. TAVR is now the preferred strategy in patients over 80. But in patients under 65 or with indications beyond severe aortic stenosis, in many situations, surgery remains the dominant approach. And the main reason is life expectancy and valve durability. We simply don't have enough long-term data for TAVR yet. However, with the advances in valve design, procedural technique, they've expanded TAVR to a more challenging patient population. In the real world, we are seeing more and more younger patients asking for less invasive options. They don't want surgery if they can avoid it. And in the last couple of years, we are starting to rethink who might be a candidate for TAVR. We're also applying it in more complex situations with patients like bicuspid valves or patients with small annuli or low flow, low gradient AS, and even exploring its role in moderate and asymptomatic disease. So at this point, we need to shift our lens from what's been already proven to what's possible and ask where TAVR is headed next. And when we talk about younger patients and TAVR, the first thing we must clarify is what do we even mean by young? Are we talking under 70, under 65, under 50? Most guidelines use 65 as a practical cutoff, but biological age doesn't always tell the full story. We have to ask, what are these patients' comorbid conditions and what is their expected lifespan? Because those factors matter just as much. The second thing we need to ask is, what is our comparison group? Are we comparing TAVR to bioprosthetic TAVR or to mechanical valves? Because that changes the durability conversation entirely. Because for a truly young patient, say in their 40s or early 50s, many surgeons would still recommend a mechanical valve. So the risk benefit calculus shifts depending on what the alternative really is. And finally, what is the evidence? And these are the foundational questions we need to ask. Because when it comes to younger patients, the data is limited and the evidence that we have is mostly retrospective. One such study from the California database looked at patients under 60 years, and after matching for baseline characteristics, TAVR was associated with significantly higher 5-year mortality. It was 11.3% compared to 3.3 with SAVR. And the reason isn't entirely clear. There was no echo data for us to look at. Another analysis from the STS-ACC TBT registry showed similar trends. Patients under 65 had worse outcomes with TAVR than older patients. But here's the catch. They also had more comorbidities and poorer baseline health, which might explain the worse outcomes. So while the results are concerning, they also reflect the limitations of retrospective data. It is unclear if TAVR itself is the issue or if it's the patients that we're selecting. Either way, it raises a critical question. Are we fully prepared to offer TAVR to younger patients with the same confidence that we do in older, lower risk ones? Because remember, when we offer TAVR to younger patients, we're not just thinking about how they'll do in the next year or two. We are making a decision that could impact them for decades. And that brings us to the next big concern. What are the long-term trade-offs for TAVR in someone who has a 30 plus years of life expectancy? So starting off with valve durability, which understandably is at the center of the conversation, this is the partner tree trial that we talked about. It followed patients for over 5 years. These were patients with severe symptomatic aortic stenosis and low surgical risk who were randomized to either TAVR or surgery. The primary endpoint was a composite of death, stroke, or rehospitalization related to the valve or bioprosthetic valve failure. And the results were similar between both groups at 5 years. And this is another study. It's a post hoc analysis of over 2,000 randomized patients from the core valve, high risk, and SOTAVI trials that showed that TAVR was associated with a significantly lower 5-year incidence of structural valve deterioration compared to surgery. And this is the NOTION trial, which gives us one of the rare 10-year follow-ups. At 10 years, there was no significant difference in the all-cause mortality, stroke, or MI between TAVR and surgery. Basically, the big outcomes were similar. And when you start looking at valve durability, TAVR had lower rates of severe structural valve deterioration. It was not statistically significant, but it was numerically lower. So when people ask, do we have 10-year data on TAVR durability? This is it. And it suggests that at least in older, lower risk patients, TAVR can hold its ground. But remember, all the patients that were included in these studies that I've talked about were mostly over 70 years old. So now that we've seen pretty solid data that's being marketed as the long-term results of TAVR, the natural question is, can we start doing TAVR in younger patients too? The short answer is no, or at least not yet. It's important to remember that long-term isn't 1 year. It's not even 5 years. 5 years just gets you from age 65 to 70. It doesn't get you to 80 or 90. So meet your average 55-year-old. And now meet your average 85-year-old. Now imagine giving them the same valve and expecting the same outcomes. Their goals are different, their lives are very different. Younger patients are more physically active, they stress their valves more compared to someone who's 80. So trying to apply partner tree or notion outcomes to a 55-year-old is probably something that we should not be doing. And when you're thinking about a younger patient, it's not just about how long the valve lasts, it's also about what else comes with the procedure, right? So, one major consideration is the risk of needing a permanent pacemaker. So, in this meta analysis of 5 trials, within 30 days, about 13% of TAVR patients needed a new pacemaker compared to just 4.5% with surgery. That's a relative risk of almost 3 times higher. Now, in an older patient, this may not seem like such a huge deal, but in a younger patient, someone who might live another 20, 30, or 40 years, this becomes a much, much bigger issue. The impact of having conduction abnormalities or pacemakers is also pretty bad. This is a meta-analysis from the European Heart Journal that showed that persistent left bundle or pacemaker implantation after TAVR were associated with increased risk of all-cause mortality and heart failure hospitalizations in 1 year. If you want to put that into a numerical perspective, if you develop a new left bundle after TAVR, your risk of dying within a year increases by 32%, and your risk of being hospitalized for heart failure goes up by 35%. And if you were to get a pacemaker after TAVR, your risk of death increases by 17%, and your heart failure hospitalizations by 18%. So, as we push TAVR into these younger and lower risk populations, we need to think beyond procedural success alone. Another key consideration is future coronary access. A significant proportion of TAVR patients have underlying coronary artery disease, and as we know that CAD is progressive, it's not uncommon that someone who gets a valve today might need a PCI a few years down the line. With SAVR, this is not a huge issue because the surgeon can align the commissures and leave the coronaries easily accessible, but TAVR is a different beast. In fact, multiple studies have tried to quantify how TAVR impacts future coronary access. We have the ReAccess trial and the ReAccess 2 studies that looked at how frequently coronary cannulation is feasible post-TAVR. And we have the CAN-ACCESS trial, which is still ongoing. It's trying to answer a really important question. Can deliberate commissural alignment improve the ability to access the coronaries later on? So the field is evolving rapidly, but it's clear that if you're going to TAVR younger patients, we can't treat coronary issue as an afterthought. It needs to be intentional from the very first implant. And moving on to asymptomatic individuals, the ones who look fine until they're not. Aortic stenosis, as we've seen before, is often a silent disease, and by the time symptoms appear, the damage may already be done, and sometimes it's irreversible, which raises the big question. Do we really need to wait for symptoms before intervening? And how can we identify patients who would benefit from earlier valve replacement? The answer is no one knows. At least in the SAVR world, there is a small trial, which is the recovery trial, which looked at the role of early surgical intervention in truly asymptomatic patients. The primary endpoint of death and operative mortality occurred in just one patient in the early surgery arm versus 11 patients in the conservative group, and that's a 91% risk reduction. And the AVATAR trial, which is another trial that showed that early SAVR in asymptomatic severe aortic stenosis can improve mortality and heart failure rehospitalization compared to conservative management. And that being said, both these trials were in SAVR patients and were relatively small, 150 and 270 patients, which means that we need further validation. But when it comes to TAVR for asymptomatic severe aortic stenosis, the data is limited. This is the early TAVR trial that randomized 900 patients to either early TAVR or clinical surveillance. After about 4 years, the trial showed a significant reduction in the primary composite endpoint of death, stroke, or unplanned cardiovascular hospitalization with early TAVR. That said, the trial hasn't been without criticism. One of the main concerns is that the observed benefit was largely driven by unplanned hospitalization rather than hard endpoint like death or stroke. In fact, nearly half of the patients in the clinical surveillance group ended up needing a valve replacement within just 6 months of randomization. Now, you could argue that this reflects the natural progression of aortic stenosis, but there's also a very, very real possibility that both these patients and their providers are now aware of this ticking time bomb and were more inclined to act sooner. This is another study that tried to bring some clarity to the timing question in asymptomatic patients, the EVOLVE trial. But this one took a different approach. Instead of randomizing all comers with asymptomatic severe aortic stenosis, EVOLVE trial tried to identify a high-risk subgroup using cardiac MRI, specifically looking for signs of mid-wall fibrosis. They enrolled 220 patients and randomized them to early valve replacement, either SAVR or TAVR, at the heart team's discretion, versus guideline-directed conservative medical management. Now, here's the thing. While the composite outcome of death or aortic stenosis related hospitalization wasn't significantly different between both groups, they did see fewer unplanned AS related hospitalization in the early intervention group, suggesting that there may be still benefit in the right population. So, where do we stand? Despite growing interest in early intervention, the current US guidelines still recommend aortic valve replacement for asymptomatic severe aortic stenosis only in select high risk scenarios, like if there's a very positive stress test or a rapid progression of disease, or if they have a peak velocity of more than 5. The European guidelines go a little bit further. They offer valve replacement when there are multiple predictors of progression, things like risk factors or structural heart changes or abnormal biomarkers, but they emphasize that this should only be done if the procedural risk is low. That being said, we are clearly in an evolving era. There are ongoing trials like the EasyAS and the Danavar, which are still recruiting, trying to answer the same question. And of course, the long-term follow-up from the early TAVR trial is going to be crucial because if you're going to start implanting valves in truly asymptomatic patients, we really need to know if they hold up over time. So far, everything that we've discussed, whether that's the early TAVR, the AVATAR or recovery, or even the current guidelines, they've been largely centered around tri-leaflet aortic valves. But what about the patients with bicuspid aortic valves? It makes up nearly 50% of severe aortic stenosis in younger patients and about a quarter of cases, even in the elderly. So their story is a little different as they come with their own unique set of procedural and structural challenges, which can be divided into three major buckets. The first is annuli. So patients with bicuspid valves generally have a larger annuli compared to tricuspid patients. But it's not just the size. The annulus may look circular at the base, but at the level of the sinuses, the bicuspid anatomy tends to be a little more elliptical. This matters because the valve sizes available in the market are very limited. And the mismatch between the anatomy and the valve geometry increases the risk of paravalvular leaks. Next up is calcification. Bicuspid patients are their valves are significantly bulkier and more heavily calcified than tricuspid valves. All of that calcium has been linked to a higher stroke risk. It increases the mechanical stress on the conduction system, raising the odds of needing a pacemaker after TAVR. Yoon and his colleagues looked at over 1,000 bicuspid aortic valve patients and found that excess leaflet calcification and a calcified raphe were independently associated with the highest 2-year mortality of reaching nearly 26%. And abnormalities in the aorta. Many patients are essentially born with structurally weaker aortic valves, putting them at risk for complications both during and after intervention. Unlike tricuspid patients, bicuspid patients can continue to show progression of aortic dilation even after surgical valve replacement. So that's something that we need to keep in mind. Given all of those hurdles, it's not surprising that the outcomes in early bicuspid TAVR patients weren't great. The first TAVR series in bicuspid patients came out in 2010, where they used the first generation balloon expandable valves, followed by a series with the second generation valves in 2014. In the earlier series, the rate of procedural complications, including paravalvular regurgitation or permanent pacemaker implantation, were high. But then came the third generation valves, where you had smaller delivery sheaths. You also had outer sealing skirts or pericardial wraps with recapturable technologies. All of these contributed to increased procedural success. And this shift marked a huge turning point. Looking at the STS TBT registry, the paravalvular leak rates dropped, the device success improved, and the mortality at 30 days and 1 year was essentially the same between bicuspid and tricuspid patients. But it's important to remember that all of the data that we've discussed so far in the bicuspid patients comes from observational studies or registries. And while that gives us valuable insights, they come with a big limitation, selection bias. Why? Because these are often the best case scenarios. Patients with bicuspid that are favorable for TAVR anatomies. The trickier anatomies, well, they often still get funneled to surgery. So we don't see them in the registry or observational study data. And this is where the Notion 2 trial comes in. It's the only prospective randomized trial so far that included a dedicated bicuspid cohort, about 100 patients with severe aortic stenosis. Small, yes, but it's the first real step towards answering the question, can TAVR be a viable default strategy in low risk bicuspid patients just beyond the carefully selected ones? So the Notion 2 trial had about 100 patients with bicuspid valves out of a total of 370. These patients were randomized 1-to-1 to either TAVR or SAVR. In the overall cohort, combining both the bicuspid and tricuspid, the primary endpoint of death, stroke, or rehospitalization wasn't significantly different between TAVR and SAVR. Things looked pretty comparable. But when you look at the bicuspid patients alone, that's when the red flags start to show. Among the bicuspid subgroup, the primary endpoint occurred in 14% of TAVR patients, while it occurred in 4% of SAVR patients. That's more than a 10% absolute difference. The paravalvular regurg occurred in 9% in bicuspid TAVR patients compared to 0% in bicuspid surgery patients. The need for permanent pacemaker was also higher in the TAVR cohort. So what does that tell us? It tells us that in bicuspid aortic stenosis, we are not quite there yet. Until we have more data, SAVR remains the preferred strategy for more patients. TAVR might still be reasonable in select patients if they have favorable anatomy with no root dilation and low calcium burden, especially if they're not surgical candidates. Okay, so moving on to women and people with small annuli. After being dismally underrepresented in most cardiovascular trials, it's about time we talk about women. Women often present with smaller aortic annuli, sometimes less than 21 millimeters, making them especially vulnerable to prosthesis patient mismatch after surgery. TAVR, with its ability to accommodate a larger effective orifice area, thanks to the lack of a sewing ring, may offer better hemodynamics and potentially better outcomes in this population. So this is the VIVA trial. It represents the first randomized trial comparing hemodynamics and clinical outcomes between TAVR and SAVR in patients with severe aortic stenosis and small aortic annulus. At 60 days, the valve hemodynamics looked pretty similar. There was no significant difference in prosthesis patient mismatch, although numerically it was almost twice as common in the surgical group. So every curve here essentially trends in favor of TAVR, especially for cardiac hospitalizations. And what's interesting here that these findings held even though some of the SAVR patients had aortic root enlargements and got newer sutureless valves, which were both meant to improve flow and hemodynamics. TAVR still came out ahead. Similarly, the very recently published RIA trial, which is a randomized trial conducted exclusively in women, over 440 women were randomized to either TAVR or SAVR. At 60 days, both groups had excellent hemodynamics. The primary outcome of all-cause mortality, stroke, or rehospitalization at 1 year were significantly lower in the TAVR group, driven mostly by fewer hospitalization. So, what does that tell us? That in women, especially those with smaller annuli, TAVR isn't just non inferior, it might actually be better. And for a group that's historically been underrepresented in cardiovascular trials, that's a win worth paying attention to. So far, we've navigated the heavily calcified territory with small annuli and trite stenosis, but native aortic regurg is a whole another challenge. For symptomatic patients or those with LV dysfunction or dilation, SAVR remains the guideline-directed recommendation. But what about those with high-risk surgical candidates? That's where TAVR has found a new role. So this is the Pantheon registry that gave us some of the insights into TAVR for native regurg, specifically using the current generation aortic stenosis valves for AR. It included about 200 high-risk surgical patients, and success rate at 30 days was not great. It was around 70%. The biggest challenges were valve migration, embolization, and residual regurgitation. The Jena valve was one of the first devices which were truly designed with native regurg in mind. It has a clip-based mechanism that holds on to the native valve leaflets, and it allows for secure positioning even in the absence of calcification. So the initial version uses a transapical access and struggled with safety, and so the device was pulled from the market. Fast forward to today, we have the Trilogy valve, which is a transfemoral iteration of the Jena valve that received the European CE market approval in 2021. The Align AR trial, I'm not going to go into too much details for the sake of time, but it included 180 symptomatic patients with severe native regurg, all treated with the Trilogy valve. Technical success was about 95%. The functional improvements were significant. The 1 and 2 year mortality were 8% and 15% respectively, but most deaths that happened in this group were due to the patient's own comorbidities, not cardiovascular causes. The J valve is another AR dedicated device with transfemoral option now available. It's useful in patients with large annuli, those beyond the size limits for the Jena valve. Compared to the aortic stenosis valves being used off-label, the aortic regurg valves, these devices, they basically offer better implantation success and fewer complications. None of them are FDA approved yet, but it's likely only a matter of time. Okay, so the last part of my lecture, as the field of the TAVR matures, we are shifting from proving that it's feasible to fine-tuning durability, access, and individualizing care. As we look into the future, there are several key questions that we haven't fully answered. First, when is the right time to intervene in asymptomatic or early-stage aortic stenosis? Second, can TAVR become the default strategy in younger, low-risk, and more active patients? These are patients with decades ahead of them, and the stakes for valve durability and reintervention planning are much higher. That brings us to the next point. How do we balance durability, future coronary access, and the feasibility of repeat TAVRs in lifetime management? With expanding indications, these technical considerations are becoming central to device choice and procedural planning. And we're already seeing how innovation is shaping the next decade. The next generation valves are incorporating many important features. We are seeing enhanced leaflet materials like Resilia, which are hypothesized to reduce calcification and improve durability. Valves are also being designed with larger frame cells, making it easy to maintain coronary access. Repeatability is another major focus. Many new devices are being engineered with future valve-in-valve procedures in mind. AI and advanced imaging are starting to play a big role. We are now seeing promising machine learning models that can flag younger or asymptomatic patients who might benefit from early valve intervention. FDA-approved machine learning tools like Precision TAVI are taking this to the next level. They're simulating TAVR outcomes ahead of time to guide personalized decisions in these patients. And finally, medical therapy after TAVR is evolving. There are trials like the RAS-TAVI and the DAP-TAVI are exploring whether medications can support ventricular remodeling and reduce heart failure events post-TAVR. And as the TAVR technology continues to advance, one thing hasn't changed at all, the heart team. from identifying the right patient early on with imaging and to procedure planning and managing recovery with tailored medical therapies. None of this happens without a cohesive multidisciplinary team. A team of surgeons, cardiologists, and of course, our incredible sonographers, the nurses and techs, every one of them play a critical role. This is our team at VCU, and I'm very proud to be a part of it. And with that, I'd like to take a moment to thank Dr. Gertz, Dr. Lawson, GK for your continued mentorship. I hope to make you all proud and carry forward everything I've learned here. Thank you all. Gaurang, it's 8, it's right on time.
Awesome.
Good morning, everyone. My name is Dr. Simon Shikari. I am the Women's Heart and Cardio-Obstetrics Cardiologist here at VCU. It is my pleasure to introduce our second Grand Rounds Fellow speaker for today. Dr. Gaurang Prabhu is a third-year cardiology fellow here at VCU. He completed medical school at Avalon University School of Medicine, followed by his internal medicine training at Eastern Virginia Medical School, where he served as chief resident and led initiatives in resident education, point of care ultrasound, and clinical reasoning. He has received multiple honors, including the Eben J. Carey MD Award for Academic Excellence, as well as Presidential Poster Award from the American College of Gastroenterology. His clinical interests include cardiac pacing and device management, transplant cardiology, and critical care. His research spans coronary CTA utilization, transplant immunology, and quality improvement in preventative cardiology. He has presented at national meetings including CHEST, ACP, and ACG, and has published in peer-reviewed journals. Academically, he is interested in cardiac embryology and the developmental origins of adult heart disease. After graduation, he will be going into private practice in West Virginia to practice what I consider general cardiology plus, including diagnostic catheterizations and EP device implantation. On a personal note, as was said about our first fellow, Gaurang is knowledgeable, well-trained, and empathetic. I hope that all those he works with and trains with and meets in the future assume that all of our fellows are as well-trained as he is. It has been my pleasure to work, teach, and learn from you, Gaurang. With that, I leave it to you.
Thank you, Dr. Shikari, for those kind words. It's an honor sharing the stage with Dr. Gadella today, and I'm looking forward to present this topic that's really close to my heart. All right. So the topic that I'm going to be discussing today is embryology of the heart through the eyes of a third-year cardiology fellow. Um, I'll start by saying the last time I looked at embryology myself was probably when I was in medical school. This is a long time ago. Since then, we just focus on the adult part of the medicine that we are specialized in, and we kind of put embryology on the back burner. It was during my congenital heart rotation when certain things started popping up, and I was curious about it, and I was thinking, what are the reasons we see these deformities? And that took me on this pathway of starting to look back on what might be the origins of these diseases and trying to dive into cardiac embryology more so. So, today's talk, my goal is to try to explain the very bare basics of embryology, how the development of just the human body happens, and more so focusing on the heart. And then once I am done explaining about how embryology happens of the heart, I want to dive into the adult diseases that we see today and correlate them to the embryological reflections of the diseases. So I'll start from the very basic fertilization. So the sperm meets the egg, and day zero right here is when you form a zygote. And the next couple of days are about active cell division. In the first and the second day of life, the first zygote is just dividing into two cells, and then three cells, four cells, and there it goes on. By the time you're reaching day four, you have a pretty compact disk of cells, which is called morula. It's around 8 cells. That's pretty much it, just 8 cells by day four. By day five, it's an exponential growth that you go into, and you end up forming these specialized group of cells. This is the first time after 5 days of life that your cells have divided into some special role to them. There is an outer cell layer that some of the cells are aligning to, and then there is an inner cell layer. The inner cell layer right here, as you can see, is the inner cell mass, and the outer cell layer, as I'll go into later on, is called the trophoblast. And as you are going through this pathway of 5 days, you're basically traveling down the fallopian tube and going towards implantation. Again, this is something that we have studied extensively in medical school, but coming back to this was a big moment for me, and I'll tell you why. So when you get to this point, you have a good inner cell mass and you have a outer cell layer. The outer cell layer is called the trophoblast. The trophoblast is what's responsible for formation of the placenta. It will form some specialized tissue called the syncytial trophoblast, and then that will further divide into giving the placenta and then implanting into the endometrium. The inner cell mass is what we are going to be focusing on mainly today. So this is the cavity. You have a cavity that's formed here called the blastocyst, and the inner cell mass, that's a group of undifferentiated cells. The cells in this group have no role at the moment, they're just hanging around. Eventually, in the next couple of days, these cells start taking a certain shape, they start organizing a certain way, and then they divide into two layers. The first one is called the epiblast, which is up top here, and then the bottom one is called the hypoblast. So from undifferentiated cells, you have almost reached to two cell layers, the epiblast layer and the hypoblast layer. As these layers are further dividing, you're forming species in their areas. So under the hypoblast, you have the primordial yolk sac. This is what's going to give you new nutrition. And the higher layer up here is called the amniotic cavity. And this is going to be the same amniotic cavity that continues on throughout your gestation. From here, we are going to go to the three layer of the germ cells, and this is one of the most important steps to understand. So how do you go from the two-layered disk to the three-layered disk? And this happens by a process called as invagination and formation of the primitive groove. So this is the top layer, this is the epiblast, and this was your hypoblast. So what ends up happening is epiblast just starts carving inside. So cells from the very center of the epiblast start falling in. They just start looping in and going towards the hypoblast layer. As these cells are going in, they form a groove because that's where the cells are basically falling into the lumen from. And this groove is called the primitive groove because it's the first groove. And all of these cells end up coming into this middle layer. And now you have three layers. And these three layers are combination of the cells that came down from the epiblast layer and some combination of the cells that came up and met them from the hypoblast layer. So you end up forming three layers of cell at this point. The top layer will be called the ectoderm. The middle layer will be called the mesoderm, and the lower level will be called the endoderm. And this is your primitive streak. That's where the cells, initially fell down from. And then these cells are just in a three-dimensional orientation, so just covering up the center part of the inner cell loop that we started off with. This is a transverse section of the same look. And another important step that we have to recognize what's happening here. As the cells were falling into that primitive groove, they're not just staying there. They kind of migrate one direction or the other. So they migrate towards, let's say, the direction of what's shown in this picture. And it migrates cranially. It migrates to that direction. And as it's migrating the direction it's going, that's what gives the embryo the direction of cranial and caudal orientation. So that's when your orientation of what part is going to start developing into the head and what part is going to start developing into the tail end is going to start defining. The central portion of the mesoderm forms this loop called as the notochord, and this becomes really important. So notochord is basically a structure. As the cells fell into the lumen, they form this nice tubular structure right in the center of the mesoderm, and it's something that will be important in the development as we go ahead on the next steps. So now you have three layers. You have your ectoderm, you have your mesoderm, endoderm, and you have a notochord right in the middle. So this is a AP view of the same thing. You have a cranial end because that's the way your notochord initially migrated, and you have your caudal end, the end away from it. And then again, you have your layers as they were: ectoderm, mesoderm, and endoderm. So notochord is a very, very specific structure. It's a very important structure. And the reason I say that Notochord is something that gives growth hormones and gives some local signaling factors to change the tissues around it. So think of it like notochord has some genes in it, and the expression of the genes is going to secrete some hormones that's going to cause the tissues around it to develop. So as the notochord is in the center, it's going to secrete some of these hormones. You have your sonic hedgehog gene and the hormones that it gives, it's a real one. There's the noggin gene and the chondroitin gene. So this notochord is going to stimulate the ectoderm to form your neural tube. So the ectoderm basically just gets, activated by it and invaginates in further, and this is what gives you your neural tube. The neural tube is what's going to form everything in the central nervous system. It's going to form your brain, it's going to form all the structures like spinal nerves and things like that. Another very important structure for us in the cardiac realm is the neural crest cells. So the notochord, as it's stimulating for you to form the neural tube and the brain, it's also forming this third layer of cells which almost falls down from the ectoderm. And this is really important at this point. So ectoderm is where your neural crest cells are coming from. And we'll dive into this further as we go down this talk. But these neural crest cells are responsible for development of some key cardiac structures. So just putting this up front, the neural crest cells help in formation of these cardiac structures, which we are very used to seeing in today's day and age. So your aortopulmonary septum comes from the neural crest cells. Your semilunar valves, that's your aortic and pulmonary valve, have a contribution from the neural crest cells. Your autonomic ganglions, they are coming from the neural crest cells. Some part of your conduction system, and again, this is not your complete conduction system, and we'll dive into this further on. Some of your conduction systems come from your neural crest cells. And why is this important? Because the majority of the heart does not develop from your ectoderm. Majority of your heart is developing from the structure called as the mesoderm, which was in the center out there. So this is a structure of the mesoderm. Again, you have your ectoderm up top here, the notochord, which is going to stimulate the ectoderm, and you have your endoderm. The mesoderm specializes to give most of the organ systems of your body or muscles of your body, is the way I look at it. So, depending on what part of the mesoderm you're looking at, it's what different organ systems they'll give. So, the lateral plate mesoderm is what's going to give you splanchnic and somatic systems, which includes your heart. Your paraxial mesoderm is going to give your muscles mainly, dermatomyocytes, and all of that stuff. And your intermediary mesoderm is going to give organs like your kidneys and gonads. So this is a video of how not cardiac, this is a video of how embryological folding happens, and this is important to understand how the cardiac cavities are formed. I'm going to play this short video here. So this is a very basic video trying to show how embryological folding is happening as we are talking about all of these organs developing. As you can see, the heart is kind of formed in the cranial end of it, and then it's folding in. So what happens if you take like basically a sheet of paper and fold it over? You're going to get some, areas of cavities in there, and that's exactly how your cardiac cavities end up forming. As you're folding through, your areas start folding in, and you get these areas where you start forming chambers, small cavities, and you form these cavities in the length of the embryo, and this length of the embryo gives you what's called as endocardial tubes. But what's causing the development of parts of the mesoderm? It's some signaling factors such as VEGF. VEGF, which is your vascular endothelial growth factor, that's what will stimulate the surrounding tissue in the mesoderm to differentiate into cardiogenic mesoderm. And it's exciting. The VEGF factors actually end up coming from the endoderm, which is the layer even further below. So it just gives you a perspective that it's not just one layer that's at interplay here. There's multiple signaling factors going on in multiple areas of the body that's driving this. Um, so VEGF stimulates the mesoderm to give you cardiac mesoderm, and then you're folding to form these cardiac tubes. So this is a picture I would say we are more familiar with in today's day. We have the cranial end and the head and the tail out here, and then different parts of the mesoderm is differentiating into different areas of the body. So your cardiogenic area and your primitive blood vessels are forming on the sides of it, and as they end up forming, you form these two heart tubes, which are your endocardial tubes, and this is how it looks in your cephalic view. You have your heart tube just forming out there, and then it's going to start folding in on itself. So this is a picture of the heart tube. This is so you form two heart tubes on two parts of the embryo, one on the left side and one on the right side. And your embryo is not only undergoing craniocaudal folding, it's also undergoing lateral folding. So as you're laterally folding, these heart tubes come together and end up fusing with each other. So this is just illustration of the same. You have an endocardial tube on the left side and on the right side, they come together. There is a fusion of the lateral myocardium and there's a fusion of the pericardium around it, just the cavity that it sat in. And all of that end up fuming to give you this fused heart tube. The structure of the heart tube is very interesting as well. You have your endo. Now, at this point, you start getting terminologies that we're used to in the adult heart. You have your endocardium, you have your myocardium, and what the myocardium does, it starts secreting this thing called as the cardiac jelly. And the cardiac jelly is what's responsible in the adult life for just giving the structure and the intracellular matter between the myocardial cells that we look at. And then you have your epicardium as well. You have your dorsal and your visceral pericardium. Right? This is just another picture of your fusion of the heart tubes. So all of these steps, cranial caudal folding, lateral folding, it's just been 20 days of life since we started with that one cell. 21st day and like about 3, 4 weeks into life, you're having fusion of your heart tubes form. And by 22 days, 25, 22 to 25 days, you're forming this primitive heart tube. And I would say this is the picture I would say a lot of us are familiar with, just knowing what part develops from what. So what, so your primitive tube is going to give you a couple of things based on where it's located. The top part of it is called the truncus arteriosus, followed by the bulbus cordis, the primitive ventricle, primitive atrium, and the sinus venosus. Different portions of this is going to give different organ system or different parts of your heart. The truncus arteriosus is going to give you your ascending aorta and your pulmonary trunk. The bulbus cordis is going to give the trabeculated part of the right ventricle and LVOT and RVOT. This again is important to differentiate. It's the trabeculated part of the right ventricle and the smooth portions of the RVOT and LVOT. And I'll go into some of the diseases talking about this, why this becomes important. Your primitive ventricle gives the trabeculated part of your left ventricle. The primitive atria give the trabeculated part of your right and your left atrium. And the sinus venosus, this is a very complex structure. The sinus venosus gives a lot of venous structures. It gives your IVC, it will form a part of your SVC. It's going to form the coronary sinus. It's going to form some of the valves that come into the right atrium. Basically, anytime you're doing a TEE, all the smooth portions that you're seeing in the right atrium is basically coming from the remnants of or formations of your sinus venosus. And again, at this point, you have your blood flow direction as well. You have an arterial end and a venous end, and blood is flowing in this direction through the embryo. So the next step is cardiac looping. As you're going through days of life, your heart is just starting to take its shape as an adult heart. And the way it looks like is the top portion just falls on the bottom portion and rotates around. That's the best way that I can describe it. And this picture does a really good job at doing the same. So you have your sinus venosus, and when you're looking at these red portions here, think of them as the SVC and the IVC, and this portion here as the LVOT, RVOT, and it gives you a good perspective about how looping happens. So this portion comes down here, the truncus arteriosus and the bulbus cordis comes down. It falls down here and then it loops around itself. It's called the C loop shaping and then the S-shaped loop. And once you come to this point, you have your left ventricle on this area, you have your right ventricle, which was the trabeculated part, going into your outflow septum, and you have your atria that have gone up top, and you have your venous structures up at the back of the heart. That's where your venous input into the heart is coming from into the adult heart. So now let's start diving into different cardiac structures and how they look different compared to the adult cardiac structures. So why do your valves look different? And by what that I mean is why does your mitral valve look different than your aortic valve if they came from the same cardiac structures? So the answer is your mitral valves are formed by the endocardial cushions. The endocardial cushion is a mesodermal origin cushion. This all of these structures that we're seeing on this diagram here are purely coming from the mesoderm. There is no other contribution. It's the local signaling that's differentiating them into different things. The muscular septum, it came from the mesoderm. So did these cushions, and these cushions end up forming your AV valve, so your mitral valve and your tricuspid valves. And it's important to understand here that because all of this came from the mesoderm, they have connections to the mesoderm. So your mitral valve and your tricuspid valve have connections via papillary muscles that we know about to the heart, because all of them are coming from the same organ systems. But now you look at your semilunar valves, which are coming from the LVOT, RVOT, but there is another cell type that's contributing to them. There is the neural crest cells. These are the same neural crest cells that came from the ectodermal origin that we spoke about at the beginning of the talk. Those neural crest cells end up migrating from the neural areas all the way down to these valve areas. And these neural crest cells end up forming, or they don't end up forming the LVOT and RVOT, but the signals that they're giving forms them differently. So this is how your semilunar valves form. This is how your aortic and your pulmonary valves form. They're forming because of a ectodermal derived origin, and that's why they look different. So the next time we look at a aortic valve and a pulmonary valve, the reason that looks different than a mitral valve and does not have the connections with the chordae tendineae and the papillary muscles is because they were formed differently. They have a different origin to them, and that kind of goes into the diseases that we'll go into. Again, the neural crest cells play a very important part here. So there are signaling factors that come from the neural crest cells that are coming from the ectodermal origin. That's going to form the outflow tracts, and that's going to cause certain changes to happen. Another important thing is bicuspid aortic valve, and I'm going to dive into that just in a moment. So, going through fellowship, obviously we have heard of the term the aortomitral curtain, and we always it's a very complex structure, and anyone who has done TE knows how complex it can be if you have an abscess in there and trying to figure out where it's going. But try to see how different the structure is when it's in the different ways it's originating. The mitral valves and the tricuspid valve here are originating from your mesoderm, and they have this bulk to them. And your aortic valve here is completely originating from the mesoderm, and you have some contribution from the neural crest cells, and your aortomitral curtain that's coming from the mesoderm as well. So this structure that you see, it's such a complex structure in development from the embryological perspective. Different things have come into play here to form this structure. And when you have an abscess in here, it's the breeding to eating through all of them. All right, so why do we see? So this was the question that, had put me in the journey of let's try to figure out what the embryology looks like, was why does bicuspid valve and coaptation go together? Obviously, med school, Turner syndrome was always the answer or to think about it, but it's the neural crest cells. The neural crest cells, they came from the neuroectoderm. They migrated down to form your LVOT, RVOT, form your aortic valves and stuff, but they also went to the aorta, and certain parts of the aorta were supposed to be differentiated based on the signals they got from the neural crest cells. You did not have the neural crest cells come down to the aorta to give it, another cusp to the aortic valve. And that same thing ended up affecting the thoracic aorta as well. And that's how you ended up getting a coactation of the aorta. And depending on the severity of that, you're going to have different abnormalities to that. Um, there are other diseases that fall in the same category. You have your tetralogy of Fallot. The neural crest cells are coming from up top here. And like I said, the structure of the LVOT, RVOT, pulmonary valve, aortic valve, they're all interrelated by what the neural crest cell signaling is looking like. So tetralogy of Fallot is like a good example of, a combination of all of it. You have your pulmonary outflow trunk, that's a abnormality. You have a VSD there because some of that part that was supposed to be formed by the signaling never formed. And this is what you end up with. There are other problems that we run into. The diagram here is shown of the the DTGAs and the L-looped ventricle and the D-looped ventricle. And these are because of abnormalities in proteins such as dynein protein. So dynein protein is something that's responsible for the ciliary motion, and ciliary motion is a very important facet of giving you the orientation of, the right directional of changes. And if you don't have this protein that's formed, you will have a wrong side loops, and you can end up having dextrocardia, or in severe cases, you can have situs inversus. All right, so diving into the conduction system, conduction system is very interesting. So, it's the formation of conduction system is purely coming, majority of it from the mesoderm, but it's local signaling pathways in the mesoderm that's differentiating these cells differently. So up here in the area of the SA node, you have certain genes that gets activated, And they've done studies about what these genes have an origin from, and they have traced back some of these origins all the way back to the monoflagellates and things like that, where they have electrical activity. So these are genes that are encoded in our genetics for millennia now, and these genes get expressed in the SA nodal area. That's where you form your SA node, and your AV node forms in similar fashion. And different genes that are expressing gives it the conduction properties of fast conduction in the atria versus slow conduction in the AV node. And then similarly, different portions of the heart are expressing different genes to get different cell types formed there that are eventually forming the conduction system. Now, if you remember, I said conduction system also has a correlation with the neural crest cells. So these are theories where they've shown some of the neural crest cells migrate in the epicardial surfaces, and they give some local, genetic action. And because of that, you have the autonomical ganglia that are distributed in certain areas of the heart based on your conduction system development there. And I'll go into that in the next couple of slides. So baroreceptors, again, going into the areas where you ended up having these neural crest cells migrate down to, you had these receptors go to the aorta, you had these receptors go to the heart. So just a simple action of having a low blood pressure, it's going to increase your heart rate. We know that. But look at the complex mechanisms from the embryological level, what's happening when this happens. So your baroreceptors stop firing or decrease their firing. The signal was a mesodermal origin signal, which is where your heart was formed from. From there, you went to the cranial nerves, which was your ectodermal origin signal. The nucleus solitarius basically processed all of this and increased the sympathetic tone. The nerve fibers came down in ectodermal origin, they stimulated it, and then they all ended up stimulating the SA node to increase your heart rate, which is back in the mesodermal origin. It just tells you, despite the heart being developed so differently, there is such complex interplay mechanisms between the ectoderm and the endoderm throughout the life. It's just the way the body develops from different layers. The coronary arteries, so this was fascinating to me because I had no idea how the coronary arteries develop. I just presumed that they came from the aorta, went down and started giving supply of blood to the heart, but it's actually the exact opposite what happens. So your sinus venosus, which was the top chamber, ends up sending cells around the heart, and these cells that go around the heart from the sinus venosus ends up differentiating further to give you something called as endocardial to epicardial transition. So when that happens, you have these specialized cells from the epicardium and the endocardium that are forming vascular bodies, and you end up forming vascular bodies on the top surface of the heart. Once you end up forming the top surface of the heart, end up forming these vascular bodies, you have something called as mesenchymal transformation that gives you some of the capillary plexus. And once you have this capillary plexus that is formed inside the heart, through certain signaling, they go backwards and end up attaching to the aorta. Now that suddenly starts making sense here. I'm going to skip a couple of slides. No, I don't have that one here. So that starts making a couple of sense here about why you have diseases like anomalous origin of coronary arteries. You forming the coronary arteries and supplying the myocardium in a certain direction. But when you go and attach to the aorta, if there is any signaling abnormality, that's where your coronary arteries are going to look different. If you have a lot of signaling abnormalities, the coronary artery might attach to the pulmonary artery, and that's when you get conditions like alpaca. It's all about how you develop these arteries and where they're attaching eventually. Um, Pulmonary veins. So for our electrophysiology colleagues, this was fascinating while I was going over this presentation. Why do we not have AFib coming from the IVC? Why does it have to come from the pulmonary veins? It's all a venous structure, right? Yes, there is myocytes in the pulmonary vein, but what's the origin of that? So as the SVC and IVC came from the sinus venosus, which was a completely different area of not having myocardial tissue, the pulmonary vein, on the other hand, came truly from the left atria. The left atria ends up invaginating on itself and forming one pulmonary vein. It forms this invagination backwards, and that atrial pulmonary vein ends up combining with the veins that are formed in the veins in the pulmonary vasculature and give you your four distinct pulmonary veins. That's why you have your atrial tissue going into the pulmonary veins, and that's why you have AFib, and our whole field of AFib ablation is done based on this principle. Conditions like ARVC. So this one it's a very loose slide, I would say. There's not too much data about that, but it kind of tracks, right? So ARVC, we know that there's this triad and there's this one area of the heart around the right ventricle that's being affected more than the others. And basically, this is the area that gets affected the most, the RVOT, and it has the same origins from the bulbous cordis. In the interest of time, I'm going to skip through this last slide here. Things like sympathetic ganglions that are sitting on the outside of the heart have the same origin. And when we do things like neurocardiac ablations, you're ablating these ganglion plexuses as well. There's a lot more about this topic that we can dive into. Again, this is a very short presentation about the same, but it was a pleasure going over this and learning about this. This is the slide I want to end with, and I want to show how different animals have different origins of their mesoderm. So this is a mouse embryo, rabbit embryo, human embryo, and this is where it all starts from. This is how you end up forming different organ systems based on different animals or insects or whatever you are. But this is the origins of life and how organs are formed. And with that, I would like to thank you all for listening to my presentation.
I think we're out of time, so we'll let people step off if they need to. And I switched computers, so I can't see if anyone has questions, but I'll look in the chat to see if anybody does want to ask a question. I'll ask a quick question for Vaishnavi. Let's say you have a 67-year-old smaller statured woman in your clinic with severe symptomatic AS. What treatment are you going to recommend for her?
I will send them to a surgeon.
I agree. I think with a mechanical valve, the patient prosthesis mismatch is not as big a question, but the surgeons might push back on root enlargement and stuff like that. So I still think that's probably the most challenging patient we encounter. But yes, for sure, the first right answer is see if a surgeon's willing to put a mechanical valve in.
I think Dr. Nas has a question. Why do you think there are such disparate TAVR outcomes between aortic stenosis and aortic regurg patients? So thank you for the question, Dr. Nas. I think aortic stenosis and regurg are fundamentally very different. Aortic stenosis, you have a lot of calcification. So if you put in a transcatheter valve, the valve is able to hold on to the calcium. And with regurg, you don't have that significant amount of calcification. So valve embolization is a real issue there. The other things, like if in aortic regurgitation you have a higher stroke volume and a regurgitant volume, that'll sort of create a suction effect, and that'll valve positioning is hard because of that. You also have like larger annulus in aortic regurgitation that will make it challenging as well. But if you take the newer generation valves, they all have this anchoring mechanism. Be it the Jenna valve or the Trilogy valve or the J valve, all of them have anchoring mechanisms that would hold on to the native valve leaflets, and so the valve migration is not an issue in that. All right. I don't think there are any more questions then. Thank you all.
Thank you, everyone. It was a pleasure.